And we're back this morning with Dr. Tim McKnight, who is in the seat comfortably and ready to talk about. We haven't talked about COVID very much because I think there have been so many aspects to this, but this morning there's something that you would like to address.
Well, yes, as a primary care provider who sees COVID patients in the office, but more so seeing them in the hospital, we've learned some things, and I think your listeners need to be aware of a few of the treatment modalities and the approach that we should take if you're diagnosed with COVID, because I see the other end when people don't do well, and I see people who do well with it in the hospital, and I think we made some really important observations that might be helpful. So there's really two phases to this treatment modality for COVID-19. The first is what we're trying to do when we're infected is trying to reduce the viral load. So when the virus invades our body, it starts to replicate. And we want to try to stop that replication as soon as we can, because after about 7 days, the viral load has really reached a peak, and we're very infected with virus. The challenge with this particular virus is that after the 7-day mark, our body gets super inflamed. We call this the cytokine storm. Cytokines are part of a chemical process that causes super inflammation. So and we have to treat that differently. So the first part of the first phase of the infection, how do you reduce the viral load? Well, so many people are waiting probably too long to get tested. So they start out with maybe a sore throat. Next day, it's a headache or a sinus, congestion. Next day, they're feeling sicker, like maybe I do have COVID, but they're not sure and they're waiting and they don't want to be tested. They don't want to call off work, maybe, and so maybe the third or fourth day, it's more apparent they've lost their taste or smell or something where they're being tested. Well, now they go get tested, and it may take 24 hours to get a result back. So they're calling us on day 6 or 7. Well, now they're behind the 8 ball. So I think our threshold to be tested needs to be much lower, especially if you're not somebody who normally gets sick or has these kind of symptoms when you have a cold. Just go get tested right away. The preventive measures that we can do even before this happens, I believe there's really good evidence that vitamin D supplementation is really helpful. We know that people who have good levels coming into the hospital, vitamin D levels coming into the hospital, tend to do much better. Their rates of transfer to the ICU because they get really sick is much, much lower than someone who's low in vitamin D.
Yeah.
So a vitamin D and zinc and vitamin C supplementation, those are all designed to keep the immune system really ramped up and ready to attack an invader. I personally believe that if you get diagnosed with COVID, the other thing that we can do is either ivermectin or hydroxychloroquine. Now, I know there's controversy about this, but there's good evidence that I've seen that this can really slow down this replicating process. And there's no harm being done in this. So I really have a hard time with the messaging that we're getting from government officials and other sources that say this is bad.
Well, lots of national media are doing that.
Well, yeah, and I think that's where the confusion comes with all of us. Like, what do we do? Who do we believe? And there are going to be listeners probably who disagree with my opinion on this, but I'm just speaking out of my understanding of medicine and science, and my interaction with patients and my experience with these modalities. I've seen it really help people. So we're trying, again, phase 1, trying to stop the replication of the virus, slow it down. Phase 2, now you've got the infection, and now it's going to do whatever it wants to do. There are some people who are more at risk for this inflammatory process getting really bad because they already have an underlying state of inflammation in their body. If you're obese, you have visceral obesity, meaning an apron of fat over your intestines. That's visceral fat. That's very inflammatory. We can monitor, we can measure the inflammation in just obese people who aren't infected by COVID. They're inflamed. Diabetics are inflamed. Those with heart disease are inflamed. Hypertension are inflamed. So those are the conditions that are already inflammatory on top of a virus that causes this superinflammation.
Which makes those people more vulnerable immediately.
Right. And that's usually those are the people that we commonly see come into the emergency room because they can't breathe. Now, the other sort of early treatment that I failed to mention on phase 1 is monoclonal antibody infusion. We know that's also very effective. So let me go back to phase 1. Get tested early. Take your vitamins. If you can get some ivermectin or hydroxychloroquine, take that, and get a monoclonal antibody infusion. Now, not everybody qualifies. If you're over 65, you qualify. If you are obese, you qualify. If you have diabetes, hypertension, heart disease, and autoimmune conditions, you qualify. If you qualify, get the infusion because it can be really helpful. It helps to knock down that replication of the virus. Unfortunately, there's so many people getting that right now that you may not get in the next day you request because there's a backlog, and it may be a couple days. But I'd say you have up to 10 days from when you test positive to get the antibody infusion. So let's go back down to phase 2. What do you do when you start to have difficulty breathing? And let's say you have to be admitted to the hospital. Well, what we do is we monitor the inflammatory response. There are 3 or 4 chemicals that we can measure. And when they come in and they're admitted on oxygen, those are very high. And we'll monitor those every couple of days. And if we see those dropping, we feel reassured that the inflammation is coming down. So we use anti-inflammatory medicines. We use steroids. Steroids are really good for that. We give people inhaled breathing treatments to open up their lungs. But there's a couple things that patients need to do. Sometimes they do these well. Often they don't do these. And those that don't do these 2 or 3 things are at high risk for decompensating and needing ventilatory support. So this is really, really important for patients and anybody with COVID to understand. If you're in the hospital, 2 things we want to do. There are 3 things. Make sure you're getting enough oxygen. We'll give you as much as we can short of a ventilator, okay? And if you need a ventilator, then we have to transfer you out. But we're trying to get oxygen into every potential space in your lungs. And most people, when they're breathing their everyday breathing, they're not getting oxygen at the bottom of their lungs. So we'll give them a tube to breathe into, take a deep breath. It's called an incentive spirometer. And we'll say, use this 10 times every hour while you're awake. And we want them to really suck a lot of air in. And we can measure how well they do this. And we'll tell them your goal is 1,000 or 1,500. And when they do that, that opens up the lungs, those little air pockets at the bottom, and it makes breathing easier. Because what happens is if you can't get oxygen, you start to use your respiratory muscles more, your diaphragm, your muscles in your ribs, and now your respiratory rate goes up. And those muscles, like any other muscle, after a while, they get tired and they just can't keep performing. Unfortunately, that happened to my sister-in-law. She was in the hospital 8 days. All she could do was think about getting enough air and using those lungs without feeling like she was suffocating. Talking on the phone was difficult. And her muscles tired out. She had to go on a ventilator. She had a few risk factors for high inflammatory state. 3 weeks on a ventilator. The lungs were damaged, irreversible, irrecoverable, and she passed away. This is just a month ago. Okay, so there were some things early on maybe she could have done a little differently. I think she did everything she could in the hospital. So breathe deep. Some people just don't do that, and I don't understand that because that's like you save your own life if you do this, right? The next thing that we know is if you'll lay on your stomach, that helps to shunt blood and oxygen to the front part of your lungs, which also often has been shown to be really helpful. And often getting blood at that area can be really useful and help those patients. But a lot of people just have a hard time laying on their stomach, right? I'm not one that lays on my stomach, so I would be challenged, but I would definitely do it. Because at this point, we're doing everything we can to reduce inflammation with steroids and breathing treatments and keeping your lungs filled. But the patients have to do something. You know, if you can get up in your hospital room and walk around, and as long as you can keep your saturation levels up, you need to expand those lungs. You've got to help yourself. And I've seen patients lay in bed curled up in a ball. Like, that's the worst. You can't get any air in your lungs, right? So it's frustrating for me to see patients who can help themselves and they refuse to do it because it's not comfortable, not something they want to do. But at that point, there's nothing more that medication can do. You're going to recover or you're going to get sicker, and you have the ability to help yourself. So phase 1, phase 2. Phase 1 is reduce the viral load with medications and supplements and antibody infusion. Phase 2, reduce the inflammatory state with steroids. That's what we do. But you have to breathe deep. You have to do the things we're asking you to do. And those people that don't do that or can't do that or won't do that, they tend to not do well. They're often transferred. And it's not always their obligation. I mean, it's not always on them. It's on us as providers, and then it's up to God. But there's so much more that I've seen patients not do enough for themselves, and I really want to emphasize that, because this county, we're one of the highest counties in the state now with COVID infections and people in the hospital with COVID, and it still continues to be an overload on the system. We tried to transfer somebody out over the weekend. The last hospital bed was taken. We called the Northeast area hotline to help us find a bed, and it was hours before we even heard back from them. This is not a time to be cavalier about this COVID virus or the infection. So get tested early, be preventive, and then do what you're asked to do if you're in the hospital.
Save your life. I mean, it might not be comfortable, but neither is dying.
No, and it's just tragic when people don't do all that they can, and I just really wanted to emphasize that. And again, I think we can do better with this. And the other thing is we need to be real careful with social distancing. I think still at this time, Thanksgiving, we're going to have people maybe from coming from different places that may carry it. We know that the vaccinated can be carriers, asymptomatic carriers. So just because you're vaccinated, or you're at a table with 10 family members who are vaccinated, who you haven't seen in a while, who have interacted and gone to work, they may be carrying the virus. So you have to be careful. But my point is, do the right things early on. Get tested early. Do all those positive things to help yourself reduce the virus, and then do the things that you need to do for breathing in the hospital.
Thanks for the explanation and the good advice. So.
Happy Thanksgiving.
Yes, happy Thanksgiving. May the turkey be the worst off when we're all said and done. And let's talk with the doc this morning.